Okay, well, welcome everybody. Our hearts are full. I mean, for all of you to be here, this is our largest attended meetup. And as you heard Roberta last night, going back to our history, when Gabriella started, she started in 1998, but this is our 19th Life Today in-person meetup. So they just keep getting bigger, bigger, and better. For friends old and new, we're so glad you found us. And once you're in our family, you're always in our family here. For those that regularly join Hope Zoom, it's amazing to see you here in person. And for those that haven't yet joined Hope Zoom or connected with us in other ways, whether it be through our Facebook page, through looking at our website, we're just so glad you found us. I'll talk a little bit more about our history tonight, but we were founded in 1998 by our founder, Gabriella Graham, and we're doing everything we can to make her proud. I'm a patient myself. I'm 14 years out, so thank you. And for those of you that don't know me, although I hope I do know everybody, if there isn't anybody I haven't met yet, make sure we connect. But Adele, Jason, and I'm the president of our board. I'd like to make some other introductions to make sure people know who's here. But someone that probably needs no introduction, my partner over there, Charmaine Skillman, also on the board. And Charmaine's out longer than I am. Charmaine, give me the number again.
28 years.
Amazing. And then my other board member, Mr. David Lemur, also needs no introduction. Thank you for being here. And then I'm going to, one of our former board members, whose husband is a current board member, Mark McMahon, couldn't make it, but Libby's here. Libby traveled all the way from California. So thanks for being here. And then, as you all know, the heart and soul of PALS is our volunteer group. We are connecting with patients day in and day out. As you know, we have our Hope Zoom calls, we have our one-on-one mentoring, and two faces of PALS are Jamie. Everyone knows Jamie. And Connie is the other face of PALS. Unfortunately, Connie could not be here. Oh, she's here. Connie, can you hear me? Connie could not be here in person, but she is here live streaming. And I have a few words from Connie that I would like to read to the group. Connie has just, and Jamie, I mean, they go over and above. They are open 24/7. They are connecting with patients and caregivers and really are talking and helping people every day. So these are Connie's words. Connie will not be present for this weekend's event. However, she is live streaming. She's just not physically in Charlotte. But she can't be here to personally hug her PALS family. As many of you are aware, her husband Willie received his diagnosis in October 2015, and she immediately connected with PMP Pals. Since then, she has volunteered as a mentor, Hope Zoom, co-host, advocating for appendix cancer patients and caregivers. She hopes this weekend brings valuable insights from our experts and guest speakers. She knows firsthand that new friendships will be formed over the weekend, and she wishes everyone an enjoyable weekend and wants to make sure we know to never give up hope. And Connie, she's given us permission, but yeah, she was recently diagnosed with a lymphoma, and so she's been a crusader going through her treatment. But as she tells us, she will let us know when she can't help. So this is not a reason to not connect with her, but we love her and appreciate everything that she does. And yeah, just some other people that I want to call out. Lindsay Wolfram. Lindsay helps with our social. Tara, where'd Tara go? Tara Collins, who recognizes. Let's see, and who am I missing? Ariel. Ariel did the meditation session this morning, and Ariel is one of our she's our athlete ambassador. So glad she's here. The Barads. Jimmy with the Barad blankets that you all received, and I'll mention it again tonight, but Life Today, over 300 of these blankets have been distributed. Lydia, who will be leading our caregiver session this afternoon. Rocky Michael, who provides entertainment. Roberta's husband provides an entertainment for us. And it goes without saying, our wonderful co-chairs of this year's meetup, Roberta Gabriel and Lindsay Barad, who worked all of their magic to get this fabulous setting, take care of all of us, work on all of the little details, and has made this just an enormously successful event. So thank you both. And from a housekeeping perspective, and tell me if I miss anything, but if you didn't get your name tag, if you didn't get your Barad blanket, if you didn't get your water bottle, make sure you connect and register. Let's see, other house.
Just find us.
Yes. We do have a full day planned. However, if you need to take a break, take a break. We'll still be here as we say on Zoom. Come as you are. Do what you need to do. So don't do what you're comfortable with. And let's see, did I miss anybody? Counting on Jamie to let me know. I think so. But certainly all of you. Oh no, Sherry and Harold. Dawes, the race. Yes. So Sherry does, and this is year 3. We're going into year 3, right, of the race. We just finished year 2. And so, Sherry has coordinated a race to celebrate a milestone birthday, and it's our 1 in a million 5K race. We have it in September, and a lot of blood, sweat, and tears goes into preparing for it, but it's very, very successful. So thank you both for everything that you do. Okay, and with that, we are going to dive right into our panel discussion. I cannot thank our guests enough for being here. We have this group that has generally volunteered their time to be with us today, and we're going to do a panel discussion of diagnosis to survivorship. We have some pre-planned questions, but we'll just, as people are interested in things, we can talk about them, and raise your hand if you have a question or comment. But I think we'll start, and rather than listen to me talk more, I'm going to ask our panelists to go around and introduce themselves. So Dr. Davis, we'll start with you.
Hi, I'm glad to be here. I'm Mellar Davis, but you can call me Mel. I am the chief for the palliative medicine at the Levine Cancer Center. I'm actually an oncologist, palliative specialist. So my initial career was as an oncologist. I trained initially because we didn't have fellowships in palliative medicine. I trained at Oxford doing sabbaticals, and then was at the Cleveland Clinic doing palliative medicine plus oncology. Eventually just graduated to doing palliative medicine alone. And so I'm chair of the subsection of palliative medicine, which is supportive oncology here at the Levine.
Good morning, everybody. Fabian Johnston. Happy to be here this morning. I'm the chair of the Department of Surgery, Atrium Health, Wake Forest Baptist, and look forward to being here. I'm not a palliative care trained person, but I say I'm a groupie because I've been doing NIH-funded research for palliative care for the past 8 years. So look forward to it.
Hi, Liz Gleeson. I'm a surgical oncologist at UNC in Chapel Hill. I've been in practice 3 years, and I am blessed to have had 2 fellowships, one in surgical oncology in New York City, and a second in hepatobiliary surgery in the United Kingdom in Edinburgh. So I have a diverse perspective on how patients approach end of life and kind of cancer in general from different countries. So happy to share that.
I'm Ed Levine. I also work with Dr. Johnston, Wake Forest, and I've been at this for a few decades now. I've been doing a lot of research in this disease since before it was popular. I'm also very pleased to be here with all of you and PMP Pals, and having known Gabriella, who started this organization, I think just this meeting is absolutely a testament to her and what she has done. When I started treating patients with this, there was nothing like this, nothing. So thank you all for being here.
Hi, everybody. My name is Laura Kahn. I'm a licensed clinical social worker. I'm a psychotherapist with Atrium Health Levine Cancer. And I've worked with Atrium for 9 years now, the past 4 years with Levine Cancer. And it's been probably the most meaningful work of my career so far. And I would really love to be able to stay in psycho-oncology for the rest of my career. And I see patients with all different forms of cancer. I don't necessarily specialize in one particular area, but from a psychological standpoint, I do specialize in treatment of anxiety disorders. And on a personal note, I'm a new mom to a 7-month-old baby girl who I'm obsessed with, and that's, just thank you. Oh, thank you. So thank you for letting me be here.
Hi, I'm Jula Veerapong. I'm a surgical oncologist at UC San Diego. I've been doing this HIPAC for a decade and a half, not as experienced as some of our esteemed panelists. But this by far is one of the best meetings that I look forward to. It's definitely less stuffy than our surgical meetings, right? And not only are you guys 1 in a million, but you guys probably represent 1 million hours of work just to get you here. So.
Hello, everybody. My name is Jeremiah Deneve. Those who know me well, most on this panel and some in the audience know me as Jig. I'm surgical oncology at the University of North Carolina. I'm partners with Liz Gleeson and pretty much know most of the panel here, either in name and certainly in association. So it's obviously an honor to join the panel here amongst a lot of colleagues, but honestly, it's a small world, friends as well. So anytime we're together, we all kind of congregate because we get to see each other so rarely, and we all very much appreciate everybody else's perspective. So obviously excited to learn from other people as well. I will give a shout out. I won't point her out, but my nurse is here, Caitlin Stouffer as well. But I will say, you as an organization, you don't recognize how invaluable you are to patients who are just dealing with a brand new diagnosis of carcinomatosis. What is PMP? What is Lamin? What is HIPEC? Whatever the case may be. And there's so much fear and anxiety and the unknown. I give your organization's product information, your website out, and so many of you are mentors, and your patient forums and so forth are such a valuable resource for so many patients and their families. So I appreciate all of you who made the effort to come to North Carolina, and certainly North Carolina is well represented here, but we've also got the West Coast represented here also. But how much you mean to us as practitioners and healthcare providers in addition to our patients and their families. I'll also just give a disclaimer to someone who couldn't be here, Dr. Trey Blazer at Duke, who also is, actively involved in this space as well, had intended to come, but he was operating 2 days ago and gets a call from his wife that his son's in an ambulance headed to the emergency room at swim practice. He bled and passed out, and it all worked out to be okay, but he's having to babysit at home, but hated that he couldn't be here as well. So Adele, thanks for the opportunity for all of us to join, and I'll let you take it from here. So.
Okay, now absolutely, thank you. I do want to acknowledge that Dr. Veerapong is the chair of our medical advisory board, and Dr. Deneve also serves on that board. So we appreciate their service in that capacity as well. So, and then I've been told it might be a little hard for the back to hear us. So when we're speaking, we'll do our best to make sure that the microphones are nearby. So we'll dive right into the first question, which is directed at the surgical oncologist, but the psychosocial and the palliative, I think, also have tangent answers to this. So the question, and maybe we'll start with Dr. Johnston. For newly diagnosed patients, what's the most important thing to know when considering surgery?
I'll hold it close so we won't have the issues in the back. Yeah, so for the patient, I think as you walk in as being informed, and many of you are very informed, but many folks don't come in haven't read as much about what this is, and you've heard the mother of all surgeries thing, right? And so, and it can be a shock to the system, because sometimes I always ask, hey, do you know why you're here? And some people, well, my doctor told me to come here. And then you leave with you're looking like a deer in headlights often, and I see the nodding of the heads because it's a lot, right? And so I think looking at organizations like this to be informed about what you're getting into is very important. We all try to do a good job of doing that, but it's a partnership, right? The idea of shared decision-making when you're looking to undergo something as big as this, it's not something as simple as a hernia repair, and even in that, there is shared decision-making that is undergone. And so I think having an understanding of what you're getting into is going to be important, because as you can think about, and what are we talking about today? The physical, the mental, the social aspect, right? And as I tell everybody, cancer is a family disease. No one does it by themselves, right? And as we see many caretakers here working together with you, and so the downstream ramifications that you've all encountered, both as patients and family members, I think that's one of the biggest things to think about when you're looking to undergo the surgery.
Thank you. Dr. Gleeson.
Yeah, so what ran through my mind is everything. I agree with everything Dr. Johnston said, but I was thinking about how if I was diagnosed, where you're diagnosed probably matters, and where you're going to get referred to, and what connections you might have. And so I think that knowing that there are options, you can get a second opinion. In the UK, there were only 2 centers that did HIPEC. In the United States, we're fortunate that there are much more centers, and actually it's one of the things that most centers are hiring for, which is really good. But it's a complex decision-making. It's a complex disease. The biology really matters of the cancer. It's really important, and the timing of chemotherapy, if a chemotherapy is appropriate, with surgery matters. And so going to a center that does this a lot I'm a big believer that you're going to be seeing somebody who has seen this over and over and over again, thousands of cases, and that's what you want as a patient, I think.
Thank you. So. Dr. Levine.
I think the question you asked was, what's the single most important thing? I would respond that there is no single most important thing. The most important thing to know is there is no single most important thing. You need to know a lot of things. And if you hear what's already coming through here, you need to know, what is your diagnosis? What are you looking at? I would tell you that you are not alone, having done this for 1,000 patients. And look for support. Look for people who know. Look for people who are experienced with the disease. Keep in mind that the average general surgeon who takes out an appendix is going to run across 2 to 3 appendiceal tumors in a career. most of us who are sitting up here and working this, I'll see more than that on a Wednesday morning before 10 o'clock. So there's a lot out there. Find where you're at and realize there's a lot to know. And then once you gather all the data you can, make the best decision for you. It needs to be tailored. Everyone's journey through the cancer experience is different, and we have to tailor it as much as possible to the patient.
Thank you. Dr. Veerapong.
I think it's about being your own advocate. What you're going through, the process is exceedingly rare, and then there's a lot of even nuances in between, amongst you. There's Lammin, there's Hammond, there's high grade, there's signet ring cell, there's goblet cell, and the average person, the average general surgeon does not know those nuances. And when you consult Google's, it's very scary. It's super scary. And so I always tell my patients, seek opinions. I'm never offended if I'm the second or third opinion. And if I'm the first opinion, I always encourage to get another opinion from someone who is well versed in the disease process that you're going through. Because when you get into a car accident, you get 3 estimates, right? I mean, this is your body. This is like the most important thing. And so I think it's about being your advocate, being well informed, finding other people who are like you to kind of share the experiences. Because I find that a lot of patients who come to me through some of the support groups that you guys are all involved in. So that's what I would say.
Thank you. Dr. Deneve.
Yeah, I don't have a lot to add that's new or novel other than to say I feel the single most important factor when considering surgery or a new diagnosis and you're coming to see someone, hopefully with experience in this space, is that there's hope. And to point, Dr. Levine's point, you're not alone. And to Dr. Gleeson's point or to Fabian's point, this is a small community, a very rare diagnosis, certainly, and to Jula's point, there are varying degrees of pathology and spectrum of disease behavior, disease burden, and ultimately outcome. And every patient's path is unique and individual, and so much of this is really a long-term relationship for the rest of your lives. I mean, how many long-term survivors, short-term survivors and long-term survivors are even represented here in the room? The reality of the situation is this is a small world for us too, and there's a lot of crosstalk and a lot of cross-collaboration, and we're very fortunate here in the state of North Carolina where, just down the road there's Duke and just down the road there's Wake Forest, and so inevitably it's very easy for me to say, hey, this is a really difficult set of circumstances, but I've got 2, 3, multiple really talented colleagues here in the state too. It's probably worth a visit to see and talk, even if it's just a video visit, because ultimately you're arming yourself with information and knowledge. And I think that's where the organization as a whole has so much value that you fully don't understand. And oftentimes it takes multiple visits before you ultimately do proceed down a surgical pathway to help work through all the nuances that have been, I think, nicely elucidated here. So.
Laura, I'm going to ask you to comment on what would you say to a newly diagnosed patient that is learning and facing the prospect of surgery and treatment?
Absolutely. Well, gosh, that's a really big question, I think, and it's certainly something that, when people come to see me, they often come when they're initially diagnosed, and sometimes they say, oh man, I wish you could have been in the room, if they, as soon as I found out or as soon as I, heard the words, I wish that I could have had a session in that moment. So sometimes I'm seeing them a few weeks out, from kind of getting their initial diagnosis, but I would say, certainly what all the providers here have said, arming yourself with information can be incredibly empowering. Of course, cancer is such a physical experience. Certainly most of the interventions are going to be medical and physical. But, a cancer diagnosis comes with really intense, it can really trigger intense emotions like anxiety and fear, uncertainty, grief, anger, all of them. And, know that that's normal. And, the more that you can kind of name those feelings, the more empowering that can be. And, as you learn more information with your providers, with your care team, your nurse navigators, whoever, know that, more information can help you feel less overwhelmed and more in control of the process, especially at a time when you don't feel like you have much control. So from an emotional standpoint, please just know that your feelings are completely valid, normal, and that probably over time, your emotions are going to change. What you experience initially, might be, at a certain level of intensity, and then as time goes on, as you get more information, as you have more of a plan with your care team, as you go through treatment, have the surgery, your emotions are going to change and evolve through this process with you.
Thank you. Dr. Davis, is it too early to get a palliative care resource on the patient care team when they're first diagnosed?
No, I don't think so. But actually, when I was an oncologist, I referred people to Paul Sugarbaker because there were very, very few people when I was in Columbus. So it was finding the right surgeon, and that was the important thing. And the second, as a palliative specialist, is never get in the way of the surgeon. And what I mean by that is that palliative specialists may not understand that this is a treatable illness, and it can be debulked, and there can be intrahepatic chemotherapy. And someone who may not be aware of that may begin to talk about advanced directives in hospice or refer to hospice. So always, you shouldn't get in the way of the surgeon. Number two is never to treat, use your medications, but not as a terminal medication. Let the surgeon do the surgery. So if there is nausea and reduced appetite, you can use a single drug like olanzapine for that. But not get into octreotide, not get into anticholinergics, because that will interfere with the surgery. So what you want to do is back the surgeon. You want to treat the pain, you want to treat the nausea, but let the surgeon do the work that they need to do. And, I think as a palliative specialist, you bring hope. This is a treatable illness. It takes aggressive care, but can be managed. And so it's important that when you have a palliative specialist, does he understand this disease? Because many don't. And that can lead to either people not getting the appropriate treatment or being transitioned to hospice where, in fact, they could have been treated and treated appropriately.
Thank you. Our next question, and we'll start with Dr. Gleeson. How do you determine if a patient is a candidate for CRS HIPEC?
Oh, that's a complicated question. Thanks for starting with me. So I think that, like I said before, the biology of the cancer is the most important factor, I think. And then two, of course, I always tell my residents and my students, we name it, we stage it, we treat it. So we name what the cancer is, so we identify the biology of it. Is it one that responds to chemotherapy? Is it one that responds to surgery? There are some cancers that are so aggressive that even with surgery, they'll recur in 3 months. We stage it. So if it's widely spread to bone, brain, lungs, liver, it's not going to be likely that a HIPEC surgery, a CRS HIPEC, is going to add much if we leave cells in other locations, right? And so we always have to do naming and staging first. I try to imprint that on all my trainees. And then we can decide whether a CRS HIPEC, and this is a very simplistic form, but I think that's really important to see that big picture, that the biology of the cancer matters, and where it's located, and if we're going to be successful. We want to be successful. We want to do surgery, but we also have to be realistic about patient's outcome. I don't want to put them through something major that's going to have complications if I'm not going to give them some additional life, right, or quality of life. So those are kind of the two things. Quality of life is a whole other topic that we should discuss as well. But hopefully that answers it. I know that was really, really broad and vague,
answer.
but it really does depend on the nuances, and that's why you need someone who knows what they're talking about.
Thank you.
So,
Dr. Levine.
Whether you're a candidate or not, this depends on a lot of things. I'm just going to build on what she started with. Appendiceal tumors, as rare as they are, there's a wide variety of them. So you need to know where they are, where it is, where it isn't. I'll put some other things into the mix, which are, what other medical comorbidities do you have? Not everybody comes to us completely healthy. Very few, frankly, come with no other medical problems. And there are some patients who have got other medical problems who are going to preclude you from doing a big operation. Some patients don't want to have surgery. If you don't want to have surgery, okay, there's other ways to get some treatment in, so that's what you need to do. But more importantly is going to be what kind of shape you're in. Do you want to have it? Can the disease be completely removed? You have to get the primary out. You have to get the bulk of the metastases out before you even think about adding something like a HIPEC to it. So those are assessments you're going to make on looking at the patient, talking to them about their problems, looking at their imaging, looking at their blood tests. And you're going to put all that together and come up to whether the patient is a candidate for the procedure or not. The other things I'll put in there is that you need to know, you need a good support system for this. These are tremendous challenges, not just to the patient, but to the family as well. And that needs to be considered. So before you come to these operations, I always tell you, you want to be in the best shape you can possibly be in, mentally, physically, spiritually, nutritionally, every which way you can be. You're like a Marine going into combat. The better shape you are going into the procedure, the more likely you are to come out the other side doing well.
Thank you. Dr. Veerapong.
I think I'll build on that as well. It's very, very nuanced. You know, in patients who have a low-grade process, I tend to offer surgery up front. In someone who has a high-grade process, I tend to offer chemotherapy. But also you do have to consider age to a certain extent, and then your performance status. For example, I did have one patient. He was 86 years old and had an abdomen full of jelly. And you know, instead of doing the big surgery, I did a hand-assisted laparoscopic just evacuation of her mucin, and you know, she benefited greatly from that. That's someone who I wouldn't go full court press in terms of getting every single bit of mucin or tumor that I can find, and I wouldn't offer the heated chemotherapy procedure, but she still benefited from a palliative debulking. So that's certainly a consideration, and like Dr. Levine said too, your social support. You know, I think a lot of us get patients from every corner of the state and other states and every corner of the United States and Hawaii, Alaska. And so you really have to make sure that when you do an operation as big as what a lot of you have gone through, that you have someone at home who can take care of you, and maybe even a physician or surgeon who can help take care of you.
Dr. Deneve?
Yeah, I think some really valuable comments here, and the only thing I would add to this on top of what already has been elucidated is that it's such a broad question and such a nuanced topic because there are so many just variables, and some key things are your level of your performance status. Age alone is not necessarily a make or break, but I think it's, you know, your level of ability to, you know, and how healthy you are, your comorbidities. One of the things that patients want to know a lot is, well, what can I do, and what can I, you know, impart to have some sort of control on outcome. And the Marine kind of analogy is so valuable here because you'd never go out and run the Charlotte Marathon without training beforehand. And ultimately, you'd like to get through it at a reasonable time and recover nicely as well. And I think from a surgery standpoint, you know, two global things that are ultimately really, really important and affect a lot of these patients are your physical conditioning status and your nutrition. Taking a daily multivitamin a day, seeing a nutritionist prior to surgery. There's a great app called MyFitnessPal. There's a bunch of apps out there, but just a great way to kind of be cognizant of your own nutritional intake. We all think we're relatively healthy. I mean, we eat salad at lunch and we eat oatmeal in the morning or whatever the case may be, but none of us are really as healthy as we think we are. And we put such a burden and a tax on your body's physiology to help you get through such a massive operation where I think nutrition and physical conditioning really go a long way. And so you don't have to go sign up for a 5K, but even, multiple times a week, 3 to 4 times a week, just 30 minutes of kind of vigorous activity. Walking in a swimming pool, as simple as it sounds, is great resistance training, especially for some patients who are maybe a little bit marginal performance status or bad knees or bad hips, whatever the case may be. Little things add up, and so.
Thank you. Dr. Johnston?
I'll only add, just to piggyback on it, what you're hearing a little bit is a lot about, there was a statement made by a surgeon named Blake Cady maybe 15, 20 years ago, and he said, biology is king. So what you've heard about is first starting Dr. Gleeson, understanding what the tumor is doing, and how aggressive and what kind of decision we make around that. Selection is queen, right? And so what you've heard most of us talk about is we're selecting you based upon your physical characteristics, the tumor characteristics, everything, all those things that are set up to make sure you can get through it. But no matter what, the prince and princess will never usurp the throne, meaning the operative skill set. And so some will say, well, just do something, right? And so no matter how skilled the surgeon is, they will never make up for the first 2 parts of decision making. And so it goes back to the first question the last question that was asked is, making sure that you're with the right person, because certainly as Dr. Levine said in the last, many general surgeons won't see this, and there's a lot of surgical oncologists that don't necessarily do this either, right? And then the medical oncologists, some believe in it, some do not believe in it, some do not understand. And so the idea of other opinions to aid in selecting the right person under this operation and get you through, because what we've used the marathon thing, you are going to run a marathon without training for it. That's what you've all done who run this operation, right? And your bodies have told you, because it takes 6 months to a year to feel relatively normal, because now you're living your new normal, right? And so all this nuanced decision-making goes into it so that we can get you on the other side of this operation.
Thank you. Our next question, what's new in surgical techniques or protocols that patients should know about? And we'll start with Dr. Levine.
There's a lot of things that are new, but the truth is what's not is probably more important. The basics have not really changed. The basic goal of this operation is to get all the disease out, spare the organs as much as possible. There are newer ways to do it, so there are some patients who are now candidates for minimally invasive procedures. Those of you who had these operations long ago had an incision from your breastbone down to your pubis. Not everybody needs that all the time, so we can potentially do more with less. If you catch it very early, there's a potential for doing it with a scope or a robot. Those are actually, frankly, very few of these sort of patients which are available. There's some new administration techniques, something called PIPEC with a P, which is pressurized intraperitoneal chemotherapy. That's not going to take the place of this. I don't know that it's been shown to be better than HIPEC by any measure. So there are some new things which are ongoing, and then there's new trials in terms of systemic treatments which are becoming available, many of them determined by genetic markers. So again, that's not a surgical question, but I think it all relates.
Okay, thank you. Dr. Veerapong, Dr. Deneve, Dr. Gleeson, Dr. Johnston, anything else to add?
I don't know if I have much to add. The surgical techniques are pretty tried and true. Patients who are, there are a few patients who are candidates for a kind of minimally invasive surgery where if you have very focal disease, you can do it with either a smaller incision or even with the laparoscope. But I think a lot of people would, advocate for a full exploration. But I echo the same things that Dr. Levine said, and clinical trials potentially. But yeah.
I would leave it to the to the panel to discuss more on the science standpoint. From a big picture standpoint, I think what to me is encouraging, Dr. Davis, briefly kind of hinted at this, with some of his comments earlier, is that I finished general surgery residency in 2010 in Atlanta, Georgia. There was not a program at the time. I finished fellowship in 2012. Where I trained for fellowship, there was not a program. Dr. Levine had been doing this and really was a pioneer. He and Sugar Baker and a few other really key people in the United States were really the pillar on which we all stand on, honestly. So we're very fortunate to have him, certainly on this panel, but honestly as a mentor, and really that's what he is. And what that has generated over time is now we all work at university programs that all train multiple highly talented residents, most of them who are not going into surgical oncology fellowship, but are going to be some of those general surgeons that then see 2 to 3 to 5 of these their career and have at least a foreknowledge of what to do and what these patients need. What you also find is that amongst all the surgical oncology fellowships as well throughout the country, these are much more established programs and aspects of their training as well. And so it's not just the Wake Forests, the Dukes, the UNCs that have specialists who specialize in this as well. And as this becomes more prevalent from a medical training standpoint, it certainly becomes more present across other institutions across the country as well. That has a trickle-down effect as well, certainly with medical oncology, palliative care, social work, whatever the specialty may be. So I do think awareness over time, and your organization is a huge part of that as well, are educating the general public. And to me, that's actually pretty exciting, because even over the course of a, so far, 15-year career, Jula and Fabian and I are the same rough era. I mean, the pendulum is swinging, I think, in a positive direction, and I think that's encouraging.
Many of our patients have recurrence, have second surgeries or third surgeries. What considerations do you think about when doing a second or a third surgery? I'll start with Dr. Veerapong.
One of the biggest considerations, again, has to do with biology. I think about how quickly the recurrence occurs. If it occurs within a couple months, then that's a situation where I would probably not recommend a repeat surgery, at least right away, at least without a trial of some kind of chemotherapy. Other considerations are, where it recurs or how diffusely it recurs. Ideally, for someone to have repeat surgery, they would have a long interval before there's recurrence. I try not to operate to do another cytoreduction or HIPEC within a year. I mean, it's already taken a year for you to recover typically. Certainly a lot of quality of life data from Dr. Levine suggests at least 3 to 6 months, a lot of times 6 months. So that's really a consideration. And sometimes when it's very limited, and if it's an indolent, if it's a kind of a slow-growing process, we can watch it. Let's just see how it goes. And for some of you, you may actually have a couple surgeries, in your lifetime, and you kind of want to spread that apart and kind of maximize each surgery, if you will.
Okay, Dr. Deneve.
We're very fortunate in Chapel Hill to be about an hour and a half away from Wake Forest, and fortunately I have somebody that I can refer to. I will say it's a great question, I think a very valid question, because the reality of the situation is, especially for long-term survivors, it's a really good problem to have. If you're 10 years out and we're dealing with recurrent disease, what other cancers, are with this burden of disease and initial presentation, do you have these, long-term outcomes? I think to Jula's point, and I think probably we could all echo, it really is dependent on the grade of the disease, the time interval to recurrence from initial HIPEC to recurrence of disease, and then patient's symptoms as well. low-grade disease, low volume of recurrence, in the absence of symptoms, I'm probably much more likely to want to observe or at least get a couple different data points, different CT scans over time to assess the progression of disease. High-grade disease with a very short interval for recurrence and or patient symptoms, to me, are pretty concerning. Will we be able to offer anything and actually clear the burden of disease? Would a trial of systemic chemotherapy be a more appropriate here? There are a lot of nuances depending on the initial grade of disease at operation, the initial burden of disease at the first operation. Was the surgeon able to clear all the disease? And there's an assessment that we all relatively use, and we all read each other's operative notes, called the completeness of cytoreduction score. But was the initial surgeon able to clear all the disease? If I see a patient as a second opinion from Dr. Johnston or Dr. Veerapong or Dr. Levine, and I read their operative note and I know, hey, they had a really good operation by a highly talented, highly skilled surgeon here, and now we're dealing with the disease, you're able to use that information to help counsel patients on ultimately, which direction would probably be most beneficial. I don't think you can undervalue the significance of there's strength and safety in numbers. And I do think in situations of recurrence as well, I think that's where second opinions and an additional perspective is really, really helpful for you as you make some of these long-term decisions for your own health care for you and your family.
Thank you. Dr. Johnston.
Fill in some blanks that I'm hearing. So one is a little bit what Dr. Deneve was saying. Sometimes we're calling recurrences depending on who you went to recurrence when it was just disease that's still there. Right, and so you were not necessarily with the right person at the right time, getting the right operation, and somebody may have told you everything's all good, but when we look back through the notes, well, it wasn't all good then, right? So there's that, helping us make some decisions. Also, where are you, right, mentally? Because if you've had a second one, you may have said after the first one, I'm never doing this again, right? And so are you mentally, you and your family, and depending on how you were with me, are we together ready to go down this road again? Because it's a journey we have to be able to walk together, right? And so we ask that question, are we ready to do this? And as others have already said, then we decide, what does it look like, right? And so for me, if you've got one small recurrence, it may be very reasonable to just say, let's watch it. There are some areas, and then I also say, well, what did we take out the last time? Right, and how are you functioning with it? So if we had to take out a lot of small bowel and you were struggling with diarrhea to this day, that's a decision we have to make together, right? There are some locations where it becomes a bigger thing. If we're able to preserve your colon, for instance, and the longer we wait, we may limit the ability to either save the colon, or we saved you from an ostomy, and now we're like, we will definitely need an ostomy, maybe more of an operation, right? There's an area called the ligament of Treitz, which is kind of the first part of the transitioning from the small intestine. In those areas, it can be a little high in real estate, and it could be a bigger operation sometimes. So thinking through the nuances of what we may need to do may drive the timeliness of when we do something. I've watched people for years, and then we've said, oh, all right, let's pull the trigger. All right, and then so as was noted, we're going to be dating for a long time, and so deciding when we do something, we're following this regularly, and it aids us in making a decision when's the right time to make that decision, shared decision making again.
Thank you. Dr. Gleeson?
So I'm a pretty hopeful person. I think all of us as surgical oncologists are, partly because we have the benefit of seeing patients who are generally fit enough to have surgery. Typically, that's the people that get referred to us. And so I'm very hopeful. So if you see me, my typical spiel for most patients, and not all patients would fit this. Again, the biology does matter. The aggressiveness of the cancer matters. But if there's a potential for more time, I think Dr. Deneve and I are very similar in that we want to give patients that chance. And sometimes the way that patients have to approach it is, this is a kind of a chronic condition. I may need, and I prepare my patients with this from day one, that you may need additional surgeries, you may need multiple surgeries through your lifetime, but It's just, people who have diabetes need insulin. So, it's just a different chronic condition. Sometimes it's a surgical type of chronic condition, and we can keep going back. Again, it all depends. There is nuance to it on the aggressiveness. I'm not going to go back every 3 months. I do put my foot down there. You shouldn't go through that as a patient, and I don't know that we're adding benefit sometimes in that situation. But for the most part, I am pretty optimistic. So if there has been a long time since the last recurrence, usually that's about a year plus, then I do think it's worthwhile. Again, if it's not widespread, if I'm not going to do harm, I can't take all of the small intestine out if that's what it takes. You wouldn't survive. So, we have to be practical, but if it's reasonable, then I say, let's do it, and let's see how much time we can give you. So,
Dr. Levine?
Getting to be at the end of this line here, so it makes it easy. I can clean up a little bit. So if you think the initial question that we had before is who's a candidate up front is nuanced, this is hyper nuanced. Yeah. This isn't two times the decision. This is X to the third power. Okay, it's a lot more complicated, and it's going to depend on everything that was said here. If you have a low-grade tumor, one of the points is not everyone has to go back. If you find something, you don't have to go back. One of my favorite lines is, if you control the tumor and the tumor doesn't control you, that is almost as good as a cure in my book. So you don't always have to go back. I've had lots of patients I've observed recurrences for, particularly for the low-grade tumors, who went on to pass on from something else. Taking them back to surgery to get that last little bit out would not have extended their life 1 minute. It would have put them through a lot of discomfort to do it. When do you do this? Basically, it's a question of what's the setting. So before you go back for a full throttle, pedal to the metal, cytoreduction, and most of these cytoreductions, these are maximum surgical efforts to clear everything out. If you can't get it all out the first time, you're not going to get it all out the second time unless you have somebody who, as Dr. Johnston's point, that wasn't quite up to the challenge. And that's something we have to look for as the surgeons who get the recurrences. But if you go to see the surgeons who are up here, people who really know what they're doing, if they can't get it all out the first time with a maximum effort, you're not going to get it out the second time with a maximal effort, more than likely. So there's still a role for surgery, and not all the surgeries have to be curative. If we can do an operation and make things better for you, that's fine. There's a notion that palliative care is all medical. It isn't. We do a lot of palliative surgery, a lot of things we do. If you know anybody who's ever had a heart bypass, when you have a heart bypass, you're not curing atherosclerosis. You're bypassing the problem. That is a palliative operation by definition. If we can change what we're doing to make this a chronic condition, which for some patients, recurrences, we can, that's what you want. And again, to echo what was said before, if you go to see your internist and you have high blood pressure, you don't expect even the smartest internist to cure you of high blood pressure. You do expect them to help you manage it over the long haul. And for some patients with recurrences, going back for a maximum cytoreduction for a second time may not be the right thing to do. Knowing when to do that, when not, that's why you really need to have a good relationship with your surgeon and your team.
Thank you. Laura, I'm going to ask you to weigh in with just some tips. So if you can imagine a patient that has been told they're watching and waiting to have that second surgery, or they might not be a surgical candidate, what kind of coping tips could you provide those patients?
Yes, I can only imagine how scary that situation would be, to sort of wonder, will I need additional surgeries? What's going to happen next? Or okay, I really want to have a second surgery or additional surgeries to feel more confident that this is at bay, but not being a candidate for it. That sounds terrifying. I think really appreciate what all the providers have shared of recognizing just how nuanced this experience can be. I think I would recommend you looking at this as sort of like a process that ebbs and flows rather than thinking sort of all or nothing. about this, like it all coming down to one surgery or one form of treatment, that this is, all of this is going to either cure me or it's going to fail. If we can sort of work on your mental flexibility a little bit through this process, that might look like, we really did all have a lot of hope for this particular surgery. We didn't anticipate another surgery, or we thought you might be a candidate. Turns out the situation has changed. Kind of having some mental flexibility and kind of living in that gray area can be really helpful for our mental health, and kind of help you prepare and walk through, these kinds of developments that can happen, multiple surgeries or, again, a change where maybe you aren't a candidate. So going to psychotherapy, utilizing your support system, acknowledging, naming feelings, those are all really important, and helpful kind of strategies to live in the gray area and kind of develop that emotional and psychological flexibility rather than having kind of this all or nothing thinking.
Thank you. And Dr. Davis, could you speak a little bit to, some of the, I don't want to say complications, but as a part of the surgery, sometimes we have pain, we have lack of sleep.
So
patients might have ostomies.
When I think of four different people, four different types. There's a recurrence without symptoms. There's a recurrence with mechanical symptoms. There's a recurrence with biologic symptoms. And there's a recurrence with biologic and mechanical symptoms. And those are different patients, basically. So one of the things that we do when we look at recurrences is we get a CT scan. And you can have radiologists look at muscle mass, muscle quality, that goes along with performance score. You can look at inflammatory markers, and if they're up, like a C-reactive protein or a neutrophil to lymphocyte ratio, that patient's also biologically sick. And so often the symptoms don't correlate with the amount of tumor. You can see people with a large amount of tumor relatively comfortable, and you can see people with small amount of tumor who are wasting away from the biologic effect of their cancer. And for surgeons, that's really very difficult. I think it's a very difficult decision to make. Recurrences who are asymptomatic, I agree. We don't want to add medicines into that. When I look at someone with a recurrence, what I try to do is look at symptom clusters. If I can use one drug to treat multiple symptoms, then that's a win-win. And I ask the patient, what symptom do I need to target? Now, it may be different when I get an ESAS or a symptom scale that I think that symptom needs to be addressed. The patient may say, no, this symptom needs to be addressed. So we try to do one thing at a time that's targeted to what the patient believes needs to be treated. And I teach patients that, that symptom management is incremental. It's rare that we hit a home run the first time around. And so there are multiple ways of approaching pain. And some people will respond to one drug and not respond to the other. There's certain drugs that I like to use if people have the risk of bowel obstruction. For instance, I like using buprenorphine and methadone, which have less effect on the bowel than other agents that occur, or something that's versatile that could be given sublingually, so that if they get nauseated, I'm not losing control in that sense. If someone has trouble with appetite and they have trouble with sleep and they have nausea, I can give a single drug called olanzapine at night, and oftentimes will target 3 different symptoms with one drug. So you're not adding a lot of polypharmacy to patients, but really targeting the symptom cluster that patients are experiencing at the time. And the symptom clusters differ from patient to patient. So we have a cluster of pain. So someone will come to me and have a lot of abdominal pain. That's one cluster. And then I'll have another cluster that will be, I have trouble sleeping, I'm nauseated, I can't eat. Or things just don't taste good to me, and that's a different cluster. So the important thing as a palliative specialist is, number one, target the symptom the patient has, use one drug for multiple symptoms, and do one thing at a time.
Oh, great advice, thank you. The next question, we will start with Dr. Deneve. How do you balance aggressive surgery with preserving a patient's quality of life?
Yeah, that's $1 million question. I wish you had started with some of my other colleagues. I think that hits home to a lot of what Dr. Davis is talking about, and kind of segues nicely into that. And kind of to Fabian's point earlier, or a point even I made, this is a long-term relationship. What ultimately is most important to you, length of life or quality of life? And several have mentioned it as time, as in their discussion of when do you operate for recurrence. Some people are very adamant they don't want an ostomy. Some people are very adamant, take everything, I don't care, ostomy or not, I just, I want the disease gone, I want to be present for as long as I can. I have some patients who come who are very young, have very young children with very aggressive disease that wasn't able to be cleared and are now developing symptoms concerning for obstruction and start bouncing in and out of the hospital and so forth, and you're really having to weigh some of these extremely challenging nuances, which is why I'm so happy you're here, because the reality of the situation, I signed up to go into surgical oncology because you wanted to help people and you wanted to cure cancer and take everything away and wrap it up in a nice little bow. This disease process and all of the spectrum that it represents, actually, I never thought in my life I would spend so much time as a palliative care surgeon, as a psychosocial kind of therapist, and a mental health therapist and a spiritual therapist, and there's so many other nuances to this. So your question is I think a very poignant one, and I'll be interested to see what the rest of the group has to say, because I really think it represents all of us together. If you were to put us up in a Venn diagram, we all deal in all of these spaces. So, Jula?
Absolutely.
But by default, I just being the nature of being a surgeon, I go in guns a-blazing, trying to get everything as much as possible. But, within the first hour of the surgery, usually I try to determine, can I get everything? And what does that entail? If I can't get everything, then I'm going to try to shift gears a little bit and see what are the things that might harm you. A tumor that's up by the liver, between your liver and your diaphragm, is probably not going to bother you. But something that's in your pelvis or kind of entangling a piece of bowel may potentially cause you harm. So I may take that portion. And then the other consideration is that sometimes technically it could be possible to remove all gross disease, but then taking 3/4 of your small intestine would not make it compatible with the kind of quality of life that you would want to have. So it really is a balance, and I really think that, I'm interested to hear what my other colleagues, esteemed colleagues on the panel will say, but sometimes it's almost an easier mindset when you can get everything out because, I'm just going to go guns a-blazing. But the hardest part is when I can't get everything out. And then now what do I do? What are the things that I focus on? It's a very complex algorithm in the operating room.
Thank you. Dr. Levine?
I think there's... Better? Okay. This is to me, when you first meet the patient, you have to look them in the eye and tell them, because the truth is when we take patients to do these sort of operative procedures, we know we're going to hurt you to do this. The reason we do that is because we can help you a lot more than we're going to hurt you, and that's why we do that. So you need to talk to the patient, what is important to the patient? we have to translate it, and Dr. Veerapong has hit some very important points here. Frankly, curative operations are much easier. The decision-making is much more straightforward. And if you can get it all out and clear everything out, you have a complete site reduction, it's very straightforward. When you cannot, and frequently you cannot, no matter how hard you try, then you have to start making compromises. The easier decision-making is the curative treatment. The tougher decisions are when you have to deal with someone and when they're going to realize if you take this out, okay, I can get a little bit more out, but they're going to pay a price for this, a dear price. And I'm not talking dollars, I mean personal price in terms of what your physical functioning is going to be. And it's how much colon do you have left? How much small bowel do you have left? And then how much time do you have left? Do you need a colostomy and those sort of things? Those are really what you're asking your surgeon to do for you at the time. Those are the tough decisions you need to make. The best way to do that is to look the patient in the eye, and you have some sort of an idea of a contract in terms of, I know what you want to do as best you can, and I'm going to try to do that technically in terms of what I can do in the operating room to put you in that position as much as you can, which sounds reasonably vague, and it is, and it all depends on what you're there, and there's going to be 10,000 different minor challenges depending on what's left. And how complete you get it out, and also wrapped up in the equation is what kind of tumor is this? If this is a laminar or a really low-grade indolent tumor, okay, I'll leave a little bit more tumor and save more bowel. If it's a higher-grade tumor, you may not have that option because the worst complication you can usually have after these recurrences is further recurrence. Most people, frankly, with this disease, if you don't treat it, they all die of bowel obstruction. That's what happens to most of the patients if you don't treat it. So if I can free up the bowel so that you can spend your time eating in a comfortable fashion, that's going to be something I'm going to prioritize in terms of trying to get the patient through the operation. Other things are on the list, but further down. And again, it's another nuanced decision. And these are the kind of things that this is going to take some experience. And to me, the most important part of this is the initial consultation when you meet the patients before the operation. You look me in the eye, I want to know what you're thinking, what your goals are, and I'll try to tell you as best I can what I can do and what I'm going to do if I can't get it all out. If we can, great, we'll all celebrate hitting the grand slam, and that's great. If you can't, those are the tougher decisions that we all have to face in surgery.
Thank you. Dr. Gleeson?
Yeah, I don't think I have much to add to what others have said up on this panel, but it is true, I think, in all of our clinics that a lot of patients come, everyone wants a cure and is hopeful for a cure, and we are as well, but I think it is wise before you meet at that initial consultation to think about, and it is a difficult mindset to put yourself in, is what if it is not curable? What are you willing to accept? What kind of quality of life are you willing to have an ostomy? These things are very difficult because you just want to be hopeful and positive, and so do we, and we are. But it is good to just have thought at least a little bit, spend some time thinking about where your limits are, because at the end of the day, that's what we need to know to best serve you. Because some of those decisions are made in the operating room when you're asleep. And so having a little bit of that conversation and come to that meeting prepared, even though it's a really difficult place to put your brain, I think is really important. And I think our colleagues can help us with that. So, yeah.
Dr. Johnston?
There's this concept called surgical buy-in. Gretchen Schwarzy is a surgeon at University of Wisconsin, and basically the concept is when you sign your consent form, you are buying in for everything. And some people think that that doesn't leave a lot of room for your autonomy and what the quality of life, and as having said that, where Dr. Levine was, where that discussion up front is really important. And many of you and many of us as clinicians aren't really asking that question, like, what's important to you, right? We often send you to a palliative care doc that then asks the question for us, but it's often later than we need to be asking that question. So we need to be asking what's important for you. And for lamins, this is for high volume disease. We're talking about this, but when we're talking about higher grade disease, more aggressive disease, again, it tends to be for higher volume, but we ask these questions, and we should be. And this is something really, it's a discussion not just with yourself, but with your family, right? Because sometimes when we're in the operating room, most of the time we're in there, we're like, okay, we can do this, but then we may need to leave the room and ask some questions to your family members who may not have had this discussion with you. Should we do this? Should we do that? And these are important things. The other thing is the first operation tends to be the most important, best operation, right? And so the easy operations, quote unquote easy, they're easier, we'll take out more stuff, we'll just move about our business. It's the ones that take more time, when we're trying to preserve, that takes a lot more time for us to do that. And so we do want to make sure that we're aligned on our mission and what we're trying to do. Certainly, most people don't want an ostomy, but as we're going through, especially with higher volume disease, that may be the thing that you need, right? And so sometimes standing in opposition, you already heard how difficult some of these decisions are. We do anguish about it. She really doesn't want an ostomy. And what you don't want us to do is make the wrong decision, which will end up hurting you and affecting your quality of life because of the perception. But on the flip side, we also acknowledge how many of you got a lot of great discussions about what this will look like, and then you're like, oh, I heard you, but this is something altogether different, right? You can only project what these experiences will look like. Hence, again, going back to why this organization is important. Someone can paint a better picture for you than I can ever can, right? Because they've gone through the experience. As much as I'm telling you, you're like, oh, well, the surgeon is blah, 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 blah. But someone who looks like you, talks like you, and live this, and with their family, that's going to be the best person that you can get to help you navigate this.
And I'm going to use that comment to plug our Hope Zoom calls. I mean, we share information, we share our experiences, and we do exactly that, where we look like each other, we've been through it, we know what it feels like, and so we can share and provide perspective that way. Dr. Davis.
Yeah, we have a paper that's going to come out in the Journal of Clinical Oncology that we've done with Jennifer Temmel, who was one of the originator of quality of life in palliative care, and Camilla Zimmerman and Dave Huey. There is a phenomena that was published in the 60s called Cadman's Gap. Now, this was really a very important concept. It is expectation versus reality. So individuals who have a expectation that meets reality, their quality of life actually will be quite high. So I have a bum knee, and we've been talking about running a marathon. If I said, I'm going to go out and run a marathon now, you can imagine what that gap would be. One of the things that happens with patients, and this was really very surprising when we were doing a study, because I was interested in hope. And I figured that symptom burden had a lot to do with hope. So the higher the symptom burden, the less hope a patient had. So I would be interviewing these patients, and they would say, oh, my pain's like a 9 out of 10 or so. So tell me about your hope. Oh, it's great. I have a lot of hope for it. So oftentimes the symptom burden doesn't correlate with the quality of life. And there's this phenomena called response shift. So patients are very resilient. And there was a very interesting study that came out of Germany that demonstrated that cancer patients had higher quality of life than the normal population. Now, why did that occur? That's because they were able to readjust. They normalized in their life that cancer. They normalized that. So, oh, I didn't want a colostomy, but you know what? 6 months later, I'm getting along fine, and I'm with family, and I'm going on vacations or so. So there is this resilience in patients that's really quite remarkable. Now, one of the things that we found in palliative medicine is it didn't seem like we changed quality of life much But the advantage of palliative medicine is we helped with that response shift. We helped them normalize that. We took care of their symptoms, helped them normalize that so they could enjoy their family and realize it's a new normal. So they reprioritized what was important to them, or rechanged, those symptom goals. So patients are really resilient individuals. So it's not just surgery, it's also the individual and how resilient that individual is and the ability to adapt to that. And I think the advantage of palliative medicine is help facilitating that response shift. In other words, if we can get symptoms down and they're enjoying their family or so, I think that makes a great big difference. And you can't measure that on a symptom scale. And that's one of the things that we found in our paper, is that most of the studies that looked at quality of life used things like a symptom scale, the EORTC QLQC30, which is a symptom scale, but patients are very much different than that particular symptom scale.
No, thank you. Great information. And yeah, the word resilience is a word we use so often in our patient community. And for all of the things that both our patients and our caregivers go through, the resilience is remarkable. And we have each other, and the hope we can give each other really plays into that. Okay, our next question, and we'll go back to Dr. Johnston to start this chain. What do you recommend for follow-up surveillance, and why do some doctors prefer MRI to CT scans?
So we're talking about timing and imaging, right?
Yes.
Okay. For lamins, I think everybody's a little bit different, but there've been some reasonable studies that say you can have longer interval follow-up, and it will not change your survival. And for me, I end up doing shorter interval follow-up. I tend to, mainly because I want to make sure I keep seeing you, keep tabs on you, right? I'll be honest, right? And make sure we're not dropping things and also, we do somewhat in those first year or two become your second primary care doc, right? And a lot of oncologists pick an oncology specialty. We do serve those roles, and people call and say, well, I'm experiencing this and I'm worried. Well, we can head those off at the pass, seeing a little earlier. So seeing, in 3 to 4 months in that first couple of years is kind of what I do, but certainly every 6 months in the first couple of years is not unreasonable as well. In terms of imaging, the MRIs tend to have a little bit more sensitivity for picking up some of the lower volume disease. Having said that, the best MRIs are what we call diffusion-weighted protocols, and even within those protocols, there are protocols to help facilitate those even better. Every radiology, it takes some work, right? So a radiology tech to do that, and every center does not have that set up, nor do they want to help facilitate the kind of MRI imaging that would be even more beneficial. I think folks in Columbia were the ones that really spent a lot of time looking at this. So the CTs are easier, they're faster. You can schedule them more easier as well. And so most of us tend to use that as a workhorse unless you have a structure and a situation to facilitate MRIs. So some of it is really just straight practical, right?
Thank you. Dr. Gleeson?
Yeah, I mean, I don't have anything new to add. I think everything you've said is spot on. I will say in my practice, just to share my experience, is that I also lean on CT because of the ease of it. Patients don't have to sit in the CT scanner for an hour. But for lamins, I actually have my own protocol. I don't know if Dr. Deneve does the same thing, but I'll alternate, especially with my younger patients, CT for the first 6 months and MRI the next 6 months, just to see. They still have to get a CT. Well, actually, lamin, I don't do chest. but I think that's a personal difference in everyone's practice. But I'll just reduce the radiation they get exposed to, and it's just a different form. I always warn my patients that, you know, it's not comparing apples to apples. So what's seen on the CT and then the MRI, we can't always compare directly, but it might give us a different lens. And then once we start getting more MRIs and CTs, we can compare the CT to the CT and then the MRI to the MRI. So that is something that I do in my practice. And then, of course, there are certain differences. Some patients can't go through an MRI, right? They have certain implants, certain metallic implants that are claustrophobia. So there are nuances. Everything that we do is the theme today is nuanced. So.
Yes. Dr. Levine?
I think when all is said and done, there's very little to choose between a CT and an MRI in terms of what it's going to detect. We already talked to you about if you have low volume recurrences from a particularly low-grade disease, that doesn't mean you're going to operate on it. Finding a 2-millimeter lesion 6 months earlier makes no difference whatsoever in terms of what's actually going to happen to you. Most surgeons that I know prefer CT scans. They're easier to get, the faster you get. I've got a CT scanner down the hall. Yeah, you can come in, you see me, you get a CAT scan in the morning, your clinic visit is done in 2 hours and you're out. As opposed, well, you come on Tuesday, you get the MRI, wait 3 days for them to read it, you then come back, then you get your next scan. And the difference in sensitivity to me is probably not worth it. There are reasons, as you said, that you don't want to get an MR. People don't tolerate them. I don't think, again, this is one of the things I think is talked about far more than is actually important. But I don't think it's that big a deal. How often you're followed up depends on what grade your disease was. If you have high-grade disease, you probably need to be seen more frequently than you have low-grade disease. Usually what I'll do is for low-grade disease, or if I'm following the patient with an oncologist, I'll usually see them every 6 months with repeat imaging, blood work if they've got active tumor markers that you can use. If you go to the UK, they follow you once a year, probably because it's harder to get, and they do their outcomes are about the same as ours. So some of these follow-up schedules, they're handed to the patients like they were handed down to Moses at Mount Sinai. And they're really not. I mean, this is plus or minus. You don't have to get to it's supposed to be 6 months. It's six months and 3 days. It's okay. It's okay. You don't have to, plus or minus a little bit is certainly all right.
I would just add, probably more importantly than sticking to the 6 months and 0 days is if you're having symptoms to let somebody know in case you need earlier interval follow imaging. I would say that's even more important than the timing.
Dr. Veerapong?
So this is a good example of if you ask 10 people what their thoughts are, you might get 10 different answers. I want to echo what was said, that really the interval of imaging has never really shown to, prolong survival. But it may change, some elements of management. I usually, use imaging in conjunction with tumor markers, and if some tumor markers are a little wonky, I might get imaging a little bit earlier. Ultimately, whether it's CT or MRI, I know I work with Dr. Barone, who's a huge MRI proponent. But ultimately, it's just like black and white TV when you really need HD TV. You kind of get an idea of what's going on. I tend to try to compare apples to apples. So if you came in with an MRI, I'll continue MRIs. If you are a woman of childbearing age, I may, lean towards MRIs. But I like CT scans because they're just easy. Here's a couple series as opposed to an MRI where you have so many series to look at. And then in terms of interval, everyone's going to be a little bit different. The low-grade processes, I usually do something like every 6 months for like 3 years, then yearly for a couple of years, and then every 2 years, something like that. But with the high-grade processes, the more aggressive subtypes, I may survey between 3 to 6 months, But ultimately, it's a very, it just depends on your disease process and where you're at, really.
The only thing I would add to this, and I think this panel highlights that, or this question specifically highlights that, when you think of colon and rectal cancer or breast cancer or prostate cancer, there are very well, clearly established guidelines for treatment, and in this case, surveillance. Given the rarity of this disease process, we unfortunately don't have that luxury. We do have consensus guidelines that we are all on and that we all, participate on. And honestly, at the end of the day, most of us follow kind of a similar kind of rough guideline. The reality is some people are Ford people, some people are Chevy people. They all get you here and get you home safely and all do a really good job. Neither of them are perfect vehicles. And I will say, as it relates to CT scan and MRI, that is the case. But there's certainly some individual nuances. The advantage we all have in the era we live in, I've been texting back and forth with my chief resident all morning long because I've got a sick patient at home. You all have access to your electronic medical record and your MyChart. So you all are very aware of your most recent blood work and your most recent imaging results. And that's really outstanding and I think helpful information. Where that becomes difficult sometimes for us as practitioners is my nurse and my nurse practitioner get messages blown up once a CT scan or an MRI report, surveillance report becomes available, because the radiologists, being very good radiologists, are going to comment on every single nook and cranny and shadow. And maybe it's real or maybe it's not, but oftentimes you see your results before we see your results, and then there's sometimes some backtracking that we have to do. To Dr. Gleason's point, Liz's point specifically, I think what is really important are your symptoms. How are you doing? How are you feeling? And those sort of things. And so as a general rule, as patients come back, whether it's CT or MRI or the preference, going through and looking specifically, we all know where these disease processes tend to recur, and that's what we're looking at every time we see a CT scan or MRI report. And I think all the more reason, if you're able to be seen and evaluated by somebody who not only does the operation but follows these patients long term, knows the patterns of recurrence or disease progression, that I think is ultimately really important as well.
Thank you. We talked a little bit earlier about preparing for surgery, that the marathon, the fitness, the nutrition. What comments can you make with regard to the recovery piece? And start with Dr. Gleeson.
Yeah, so I always counsel my patients how important it is to prehab, I call it prehab, to prehabilitate yourself and train for this big operation. And then the other thing I always tell my patients is you get to sleep after the surgery on day 0, but day 1, it's tough love at UNC. We do expect you to get out of bed on day 1 and walk. We know that patients who ambulate or walk early after surgery recover faster. So we want you to move. The body responds very well to movement. It does hurt, but we have adjuncts to help provide pain relief. I like the epidural. We also have PCA, which is the patient-controlled analgesia, and we have lots of medications at our disposal. If you have an epidural, you get the pain team to round on you every day, so I always push that because they'll see you twice a day at UNC, so they're very involved in making sure that you're comfortable. And so we want to relieve your pain so you can move. The GI tract responds to it. There's only level 1 evidence, meaning the only randomized controlled trials that have proven that the gut wakes up faster after surgery is walking and chewing gum. I wish hospitals provided gum, but they don't. So bring gum. Tell your family members to get you gum, because those are the only 2 things. Medicine doesn't seem to work. So I always tell patients that. I want you to walk, get out of bed, and move as much as you can. Recovery is going to be a long process, and it's dependent on how much is done, how much disease there is, how many organs are removed. All of those things do factor. So it's not a blanket statement. I can't tell you, all HIPECs recover at this rate. So it is dependent, and sometimes we don't know that, like we've said before, until the day of surgery, because we didn't expect to have to remove the spleen, for example. Not that the recovery after taking out the spleen adds much to if you're having other organs and GI tract removed. But yeah, so it is dependent on how much is done. And the other thing I want to speak to is the flexibility of your mind, because I think that's so important. Focus on the things that you can control, and then, because you can't control the other things, but you can control if you walk, you can control if you move. You can control if you smoke. Some of the decisions that you make do affect your recovery. And smoking is a big proponent. We know that for healing. It impairs healing. So there are things that you can control as a patient, and I want my patients to be empowered to take control of those things and to mitigate the risk post-operatively. I think I'll stop there.
Thank you. Dr. Levine?
Okay, I get to add-ons, which is nice. And again, one of the points I think people need to know when they're coming in for these operations is, again, a lot of people think of the hospital as a place you go to rest. It ain't. Okay? This is Marine Corps boot camp. You are on your feet, soldier, and let's get moving. And the reason is not because we're trying to torture anybody. You will do better if we keep you up and moving. The real limiter in terms of the rate of recovery for most of these procedures is how much gut surgery do you have to do. So if you take out a spleen or a gallbladder or an appendix, that's not a big hit. If you take out 2 pieces of colon, 2 pieces of small bowel, you have an ileostomy, on and on and on, that's really what's going to determine how fast usually your bowel comes back online and whether you have complications or not after the procedure. So what can you do? Positive mental attitude. You cannot bottle that. I cannot inject that into you. You have to bring that with you. And that's part of preparing ahead of time. The more prepared you are ahead of time, the better you're going to do afterwards. And these are not things which are often measured in surgical research trials. I've done a lot of research on outcomes and quality of life and what makes people go afterwards. Those are the key elements. But again, what usually makes it, some patients, you operate on them and they are, okay, let's go, and you have to hold them back. I like those guys. Those are great. Other patients, you operate on them, and they sounded really good, and they want to be active, and you meet them after surgery, and they look like a lump of Jell-O that's just laying there in bed. You cannot get people to move, and you have to tailor what you're doing to them. So if you bring a positive attitude with you, realize you're going to have to get up and move when it isn't easy. You're going to be hooked up to tubes and IV lines and leg squeezers, EKG leads, da-da-da. None of this is fun or pleasant, but that's actually a lot of the stuff that makes it better. Chewing gum, again, there's actually a randomized trial that shows that. I recommend sugar-free so I don't get in trouble with your dentist, but bring some gum with you. Our hospital also will not give you gum, but we have a prospective there. There's actually a medication, L-tryptophan, I think, which has been shown to cut the ileus rate by about a day. I'm not sure that's worth it, to be honest, because most of the people are in the hospital for longer than that. So there really aren't that many things we can do. The best medicine we can give you after surgery to get your bowels to work better is what I call the tincture of time, and which is the hardest medicine to take of all.
Dr. Veerapong?
The tincture of time, or TOT, is very key here in recovery. But a lot of times, I know we harp on it, but a lot of times your prehab status before surgery really determines your rehab status. So we always try to get patients to aggressively think in terms of have a trimodal mindset of movement, nutrition, and anxiety and stress reduction, because that'll ultimately carry through to the postoperative phase. We are actually fortunate through our enhanced recovery program and through our enhanced recovery nurse to actually have sugar-free gum for our patients. So the component of post-op recovery is there's this entity called enhanced recovery after surgery, where we try to get you moving as soon as possible, eating as soon as possible as the surgery allows, getting you walking as soon as possible, getting you to do these lung expansion exercises as soon as possible. But ultimately, I think you have to keep in mind too that your surgery will also dictate some of your postoperative recovery. It really does take upwards of 3 to 6 months before you start feeling your new baseline self. When you go through this big surgery, you will lose weight. You will have decreased appetite. A lot of my patients complain that, food doesn't taste the same, or it's bland or metallic. But then, after 6 or 8 weeks, some of my patients come back and there's this switch. I don't know if I can explain it. Maybe Dr. Levine has some wisdom to share, but sometimes I'll say, just stick with it. It'll get better. And then, in 2 weeks in the next clinic visit, my patients will say, oh, wow, I can eat a burger now. I don't suggest that, but
I'll weigh in here, and if it's okay, Adele,
Yeah.
I'm going to shift the question a little bit, and there's
Yeah.
3 people I'd like to weigh in. And the background for this is I was at the Advanced Cancer Therapies meeting, this was probably 4 or 5 years ago, and one of the research assistants, I don't even know that she was a surgeon, but actually spoke on sleep health after cytoreduction and HIPAC. And so we know globally across multiple different studies that quality of life and performance status initially after surgery decreases, as expected, recovering from really large operations, but generally by 6 months returns about to baseline and hopefully improves from what it was preoperatively. So for really, for Laura, for Ed, for Dr. Davis, beyond 6 months, beyond a year, at what point do you really start to evaluate the mental health changes of what you've been through and where you are currently compared to where you were beforehand? Your sleep health, your intimacy health with your partner as well, and discussions specifically related to that. I think we do a really good job of trying to control the variables related to surgery and getting you back to baseline. But these other mental, emotional, spiritual health issues, I think sometimes we as surgeons probably don't focus on enough. So perhaps y'all could weigh in and provide some insight as well.
Again, done a lot of research on this issue, and I learned a couple of things that I didn't anticipate. If you look at long-term survivors or patients, it's going to take somewhere between 1 and 6 months to get over one of these. In all the quality of life studies, believe it or not, Dr. Davis is going to tell you there's limitations to quality of life studies the way we do them. He's right. But one of the things that came out of it, which I never expected, was I'll give you 3 things. Number 1, sleep disturbances are present in 20% of you, 20% of patients that we studied anyway, afterwards that are persistent. And how you treat those, that's not an easy thing to fix. I have to tell you, there's all sorts of things we'll talk to you about, melatonin and Benadryl. People give them a glass of whatever you drink before you go to sleep. Turn off your lights, make sure it's dark at night. Don't play with any video screens for half hour before you sleep. There's also what they call sleep hygiene, which has got me way further into the sleep world than I ever dreamed it would be. That's number 1. Number 2 is PTSD. So this is something I ask you to think about. So PTSD is something we used to talk about soldiers coming back from battle. And what does that actually come from? PTSD is not unique to the military. PTSD comes from going through a tremendous, highly stressful situation, which is a threat to life, upon which you do not have ultimate complete control, and it's going to leave you with some internal scars. I'm looking around, I'm seeing a lot of head shaking. That's what you've been through, guys. That's exactly defines what this is. And PTSD, again, another thing, that's going to get her on the board in just a couple of seconds, but that is something that comes out of our quality of life work. A couple of other things that come out is the caregivers. Interestingly, if you look at the symptoms of the caregivers, they are more long-lasting than the ones from the patients. And what are people complaining about in terms of caregivers and patients a year later? Something else I didn't anticipate, financial toxicity. This is going to cost you a lot. It actually comes on to dollars, availability to return to work, calling in favors, getting people to take care of your kids, your family, your dogs, mow the lawn, on and on. Those are things that came out of the quality of life work we did, which has led me to get palliative care people involved, psychosocial people involved, and you need a team, which is a very long answer to Jig's question here, I'm afraid.
I have so many thoughts. I will try to condense it, though. One, I so appreciate you bringing up kind of the concept of trauma and this being potentially a traumatic experience for you guys. Trauma is very subjective. You could experience the same exact event, same exact surgery, but have a completely different emotional, or psychological response to it. In terms of kind of timeline of, when you start to, notice, okay, what are some lingering effects? Am I still struggling with insomnia? How am I adjusting emotionally, psychologically? How are my relationships doing? How are my finances doing? There's really this is not you might not like this, but there's no specific timeline for kind of adjusting to all those things. But one of the skills, and it is a skill that can be really, really helpful to help you adjust through, immediately post-surgery and getting up out of bed in the hospital all the way to getting home, maybe, doing some kind of rehab if you need to, getting back into your lifestyle, is self-compassion. And it is a skill. It's something we need to practice, and it is something that we can build up like a muscle. A lot of times, and I'm sure many of you have experienced this, where, expectation versus reality is very different. You might have envisioned yourself being able to just pop right up out of bed and get moving, and that your progress would look a certain way, that you'd be able to adjust, quickly or at a certain pace, or with a certain ease. And when that's different, that can be shocking. It can be disappointing. It can bring in grief and fear and anger. It has implications for your loved ones and how they support you. So, regardless of your situation and, how your physical recovery is going, I would encourage you to try to practice self-compassion. Notice your feelings, acknowledge them, stay out of judgment as best as you can, saying, oh, I should be here, I should do this. If you're saying should, you're judging yourself or you're judging the process. So, as best you can, if you can kind of, just acknowledge, like, okay, I'm doing the best I can. Yes, today I'm going a little bit slower with this. This is what I can do right now, kind of reaching more of neutrality. And being kind and gentle to yourself is going to help with that mental flexibility and help you adjust long term. Also, on a sleep note, there's cognitive behavioral therapy specifically for insomnia. So if you need that target, if sleep hygiene isn't cutting it, please go to a psychotherapist or psychologist that specializes in CBTI for insomnia.
Dr. Davis.
Yeah, I'm blessed to work in a department that has acupuncture, music therapy, multimodality integrated therapies. So, and these appeal to different groups of patients. That's important. Now, in the postoperative setting, I'm known for opioid therapy, but it's one place where if you can minimize opioids, you get better recovery. So when I had my surgery, I had an epidural bupivacaine and no opioid, and I could recover fairly quickly from that. But I do remember, and this has to do with sleep, people coming in and giving and taking vitals when I was doing fine, and then walking out and leaving the lights on. So I had to get out of bed and turn the lights off. Well, that just broke my sleep pattern. And so sometimes the best thing to do is actually have people sleep well. So insomnia will lower pain thresholds and will produce fatigue. So if someone's fatigued, we don't have really a major medicine for fatigue. The best approach is to get them to sleep better. And oftentimes that'll raise pain thresholds and actually improve fatigue. Walking, that's the other thing. What the surgeons are teaching us and what we're trying to do in patients receiving treatments for various malignancies is walk. That will reduce, if there's anything that will reduce the fatigue and improve the physical quality of life, is obviously being more active in that regard. So one of the things that I'm very interested in, and I'm in the middle of writing a paper on this for drugs, is there are a group of opioids that are G protein biased, kappa agonists. Now, and kappa agonists somehow do well treating visceral pain for some reason. We don't quite understand. But these opioids, this group of opioids, and they've just recently been developed by multiple groups, don't produce addiction, don't produce respiratory depression, don't produce constipation, and they don't produce dysphoria or aversion. So I think that in the things that can be developed in the future, we may actually have a different set of analgesics that will be safer, more compatible with surgical recovery, and keep people comfortable.
Amazing. Dr. Johnston, did you want to make any additional comments?
I'll keep it short. I think the compassion part is very important. There's this wide breadth, right? You've heard of people, Dr. Levine, people look like Jello afterwards, and then there are people who don't know how to chill out. You guys know who you are, right? After surgery, and on the flip side, then you have the caregivers that are have the whips that are trying to drive you, and you remember the arguments that you had with your partners and your kids and your family members saying, get up, move, or chill the hell out. And so, again, everybody needs to have compassion for each other in these moments, and on both sides to facilitate that recovery. And it's hard in having these discussions. So we try and have these discussions in clinic, so you know, hey, this is going to be hard. And I think the last thing I'll say is for the dudes often are duding after surgery. They're like, it's going to be okay. And then something dumb happens because you want to be a dude. Like, nobody has time for that, right? And so listen to the women in your lives just like you would otherwise, so you can have a good outcome.
So well said. Thank you. Staying on the caregiver topic, what is one thing you wish every caregiver understood about supporting a patient through major surgery? And I think we'll stay with Dr. Johnston to start this question.
Well, what does the caregiver should understand?
Yes.
It's hard, right? I think, why can't you just get up? Why can't you just do this, right? And you're sitting there like, do you see me? And I think there is also, on the flip side, patients sometimes feel a guilt often that they're putting you through this, right? And so they're grappling with their guilt while trying to recover, and you're grappling with your guilt as well. And so acknowledging these feelings that you're really having, and again, it's not always easy to be introspective in a moment, but at the same time, we do need to acknowledge these things to allow us to then move to the next step, like what do we do now that I can name it, right? How do I respond? How do I act in these moments so that I can truly be there fully for the person, or communicate with that person and say, this is what you're doing, and you may feel guilty, like you're being kind of a butthead. These are words we'll use because there are cameras, all right? Or you're being this way, and I want to be there fully for you, but it's hard because of this. That's why rates of divorces are so much higher after going through this, right? And it's on both sides. And so just kind of, again, acknowledging, being introspective about how you're feeling and having these conversations in the moment, I think are really valuable for people to do.
Thank you. Dr. Gleeson?
I would say I want my caregivers to feel empowered. If they have a question when meeting with me that the patient hasn't asked, I'm happy to answer that as well. I'm even happy to answer it as a separate phone call or outside the room if they're inpatient. So I want the caregivers to feel empowered, because at the end of the day, they're going to be going home with the patient, and they are going to be seeing the after effects of the surgery and the recovery. And the other thing I want them to feel empowered to do is to recognize, something doesn't look right. I know my significant other or whomever, the patient, and there's something wrong. Even if the patient doesn't, no, I'm fine, I'm just recovering from surgery. I do want my caregivers to feel empowered to say, I think we should explore this, right? I think we should call about something, because the sooner you can get, these are complicated surgeries, right? They come with complications. And so the sooner that you can get to a hospital and to, healthcare center, the better. And we can figure it out sooner. So that's all I'll add.
All right. Dr. Levine?
Caregivers is an ever-increasing area of the research that I've been doing. And I think what I would say to the caregivers at the outset is, this is a marathon, not a sprint. Even a mediocre caregiver is good for about a week. You get 3 or 4 weeks in and say, wait a minute, I've made the bed every day for 3 weeks. You haven't done anything. You can't wash the dishes. Come on. And that stuff, it adds up. And then you're going to switch into some of these things as time goes on, which some Dr. Johnston could have. There's a guilt. I feel fine. Boy, why do I feel fine when you feel so crummy for so long? So I think it's a long-term commitment, and they are probably, in my view, the most undervalued part of the team. The people who are absolutely doing a lot of the heavy lifting in terms of getting people through. When they're in the hospital, you got nurses and nurses' aides and mobility people and respiratory therapists and all kinds of folks. You get home, somebody's got to feed the dog, somebody's got to take out the trash. You're not going to drive out and be able to get any groceries. Having the caregivers ready for those sort of things, and it's a long-term, it's a sprint. And I will tell you, one of the things that's been helpful for my caregivers is give yourself a break. If you stand there and you're staring at the patient 24 hours, 7 days a week, the walls are going to start closing in on you. You're going to feel crummy. You'll take better care of somebody else if you take a break once in a while for yourself. So your own mental health break, and you'll be there for your loved one longer and better than you would be if you just stood there and stared at them.
I have a thought on that too. Absolutely, caregivers are one of the pillars, of a patient's care. Of course, carry a huge amount of responsibility for something that they don't have control over. And I think when I work with caregivers and they're in session, they really struggle with a loss of control as well, because many times they would rather trade places with the patient with cancer. Because they think, I can handle this. But it's torture, seeing my spouse, my loved one, go through this. I think I think a lot of times caregivers feel like they have to always put on a brave face and be supportive no matter what, and kind of deny or minimize their own needs because, well, look what the other person's going through. Well, they have it worse than me. We do a lot of comparing with that. And, we don't need to compare. We don't need to pretend that, we're not feeling difficult feelings. We don't need to pretend that we're not scared. We don't need to pretend that we're not tired. We don't need to, deny or minimize, what you're going through, your own experience as a caregiver. So that's just a reminder of, name your feelings, share them with the patient. That provides an opportunity for you all to be open and honest with each other about what you're both feeling and what you both need. Let the patient do some things for themselves, let them help you sometimes as well when they can, however they can. That makes patients feel better too. And, caregivers, you don't have to have the answers for everything that, your loved one's going through. When we can just approach it with vulnerability and compassion, that keeps us going more than, necessarily having answers for things or solutions to every problem.
Yeah, I think being a caregiver is probably one of the toughest things to do. I mean, you are the physical therapist, you are the nurse, you are a lot of times the doctor taking care of your loved one. You're expected to do it all. You're the transport person taking your loved one to clinic. And then, if an ostomy appliance spills or if there's an episode of incontinence, it's just very tough. It's not something that, if on the one hand, if you're a nurse, you're trained for that. You do that on a day-to-day. But a lot of these things you pick up on the fly. And then there's the whole idea of guilt too. I mean, you're the healthy one, and then you feel like you have to be there for your loved one, and then maybe if you can't take your loved one to the clinic one day, you're like, you feel like a jerk, or you have that perception, but ultimately I think you have to, as a caregiver, one has to be able to, have some self-care as well, and understand that you have to fill your cup before you can fill another person's cup. So I think it's a very unique entity, the caregiver guilt, but it's a tough job, and in some ways it's tougher than being the nurse, being the physical therapist, being the surgeon.
Yeah, not a lot to add other than to say you're not alone. 3 years ago, when I moved to North Carolina to start a new practice, what are some of the most difficult life things you go through? You move, new job, new marriage, divorce, you lose a job, whatever the case may be. My father was diagnosed with small bowel adenocarcinoma with carcinomatosis, so presented with a malignant bowel obstruction, so a very zebra diagnosis, and it falls in our world. And my poor mother, high school English teacher, has no knowledge of medicine, learned how to hang TPN and deal with the G-tube. He developed a second obstruction, and ultimately he had to have an ostomy as well. And so now my mother, who has no knowledge at all of medicine, becomes a mini expert at all of these different nuances, of his care. Providentially, my father's still alive and still with us, and has had some great, healthcare providers at UAB helping to care for him. All that to say, I still get a phone call every time they are on their way to either the infusion center or to go get a CAT scan because of anxiety and concern and fear and guilt and so many of the things that you've heard mentioned today. At the end of the day, while our relationship is with the patient going through the process, the reality is that our relationship is with you as well, because you are such a key part of that also. And at the end of the day, if you can barely swim, you cannot save a drowning person as well. Meaning, you also need to do these same steps that we recommend for patients for self-care, for healthy nutrition and mental and physical, whatever the case may be, because you're also going through this process. And oftentimes, and I think, Dr. Levine mentioned this, that they identified through their quality of life studies, the patient's caregivers have even more significant negative symptoms than the patients will sometimes as well. Everybody comes with different motivations and different, issues that they're working through. But I think taking care of yourself can't be understated, and you really aren't alone. Y'all are obviously a huge part of that as well, but to pick off of what everybody else has said. So,
Dr. Davis?
Yeah, a couple points I want to make is many caregivers are Italian mothers, because oftentimes they complain the patient's not eating, the patient doesn't complain of eating. So sometimes you get better symptoms from the caregiver than you do from the patient. So always listen to the caregiver. Secondly, there are cultural differences. I taught in China in the 2000s, and the filial approach is very different in China. So you have to be aware as a physician, what is the cultural background to their caregiving? There's certain cultures in which they don't want hospice involved because that's their job. That's what they're supposed to do. So it's important to see where the caregiver is in that regard. So, and third is, particularly in someone who is ill, someone can't be on 24 hours, 7 days a week. So I begin to talk about who else do you have. You can't take more than an 8-hour shift in someone who may be recovering, may need close observation, can't be left alone. And I used the fall or can you get out if the house was burning incident to determine, what there are. So a single caregiver will actually, their health will dramatically fail. The last thing I want to say is I failed in employing a caregiver when I had my surgery. I was embarrassed. And so as a patient, I was embarrassed about the surgery. I knew it was a cancer surgery. But still, psychologically, as a physician, or even though I was a physician, I was an individual to this. And I didn't employ my wife, and I kept her away from that. And so it's important to counsel the patient to employ the caregiver. You are a team together with it. And the last thing I want to say is communication is may be very different than what seems to be normal. So I had one patient who had a brain tumor, and I kept asking him the question, and the wife kept answering the question. He was capable of answering the question. It may have taken him a little bit longer. But I violated the way that they communicated, and she wrote me a letter back. It was a real education for me, that he had already always spoken for her. She never responded, but he always responded. It was his job, and she had taken over that role. So the other thing that I have to be very careful about is, how do you communicate? What is the best way to communicate? Because it may be very different than what I perceive is normal. It may be the way that they actually cope with the illness, and it may be a communication pattern distinctly different than what I'm used to.
Thank you. Well, we could be here all day, as you can tell, and we're bumping into lunch, and so, and Dr. Johnston has another appointment, but I'm just going to ask the panelists. We'll start with Dr. Johnson. 30 seconds, just some closing comments.
I'm going to keep it short because I have to go to a soccer game in Greensboro. Just keep doing what you're doing. Keep advocating. Keep being the people that each other need and the people that are out there, and send them all up to PMP Pals to make sure they're taken care of.
Oh, thank you.
I think the fact that everyone is here speaks volumes, and I think what you're doing is excellent. I think that with such a rare disease, we need people like you who can help other patients. And so I applaud you all for being here. So thank you.
I'm going to put out the obvious, and this is something I've been dealing with for patients since I started this 30-something years ago. You're not alone. You're not alone. You're not alone. When somebody gives you a diagnosis, you feel like you are the only person on the continent. And now you're not. And an organization such as this, you cannot possibly undervalue the camaraderie, the support, the knowing that you're not alone. You're not the only person to go down this road. There are people here to help you. The doctors and nurses, we're all going to help you, yes. But the kind of support you can get from this sort of, from the PALs, I don't think you can underestimate its utility. And for those who had to go through before, when it wasn't available, they'll be able to tell you exactly how important this is.
Wow, you guys have made an incredible community for yourselves. You've found your people, and that's what I would encourage anybody who's going through any form of cancer, any chronic condition, is to find your people. And because you aren't alone, you can't go through this by yourself, and you don't, more importantly, you don't have to go through this by yourself, either as a patient or as a caregiver. A specific resource that I'd love to share for those of you who enjoy TED Talks, there's a wonderful TED Talk by Dr., I think her first name is Kelly McGonigal. She's a health psychologist. She has, it's called, if you can just YouTube it, How to Make Stress Your Friend. There's a great deal of research on how your perception of what your body is capable of before going into surgery actually improves your health response, the health outcome afterwards. It actually activates your immune system in a different way. It heals your body. Tissues actually react to our beliefs. And so if you believe that your body is helping you through this, is capable of recovering, adjusting to whatever changes that surgery brings to your lives, if you believe that your body is helping you and that, that stress is actually a helpful response for you, your body will respond accordingly and more favorably than if you believe that things are not going to work out or that you aren't able to adjust to this. So, How to Make Stress Your Friend is a great TED Talk.
I was just thinking that, with all the questions, that that have been asked and answered, that as similar as your experiences all have been, you guys all really are very different and unique. I mean, you guys have a 1 in a million diagnosis, but even like within the 1 in a million, you have like 1 in another million subset within that. And then when you compare your experiences of how you got to where you were, like how your diagnosis was arrived, whether it was from a gynecologic oncologist or just having appendicitis in the emergency room or having a hernia randomly repaired, that's such a unique experience. And then when you compare your surgeries, like how many of you like still have the same organs as, you know, how many organs have you guys had removed? So you all are very unique, and it's just kind of nice that in the whole differenceness of things, you guys have a commonality.
Yeah, I would just have to say in parting thoughts, thank you. You come to us looking for guidance, for hope, hopefully for a cure as well, to glean from our experience and our highlights. The reality is we learn every bit as much from you as you learn from us, and it's a cumulative process. And so each and every one of you affects each and every other patient we treat. So you are a part of everyone else's legacy. And so I think there's power in that. And as I mentioned earlier in the panel discussion, this is a long-term relationship. There's value to that. That is, I think, the reason we are all on this panel, because we have chosen this aspect of oncology to treat, because you develop relationships. We feel every high with you. We feel every low with you. When you're struggling with a complication, when you're struggling with loss, we feel it too. I take it home with me as much as I try not to. I think we all do. You can't do what you do and meet people where they are at some of the most difficult times in their life and not develop just some sort of emotional bond with the patient, with their caregivers, whatever the case may be. And we are better because of that. And so I thank you all for what you do and what you give to us. Your strength, your grace, your compassion, your fortitude inspire us to do what we continue to do when it's hard and it's difficult and we don't know the answers and we're struggling as well. So your struggle is not in vain. So thank you.
I have learned so much from caregivers and patients. I think that has been my large education. But what I would say and what I am trying to learn is to live in the moment. So the past is past. The future, even if you fear it, there's nothing that you can do about it. But you have yourself and you have your loved one now. So oftentimes I sacrifice the moment worrying about the future or ruminating about the past. But one of the things that we hope we all give is giving you guys the moment with your family, the moment together, the things that make life worthwhile.
Well, on behalf of our PMP Pals community, we can't thank you enough for spending your time with us, sharing your insights and your perspectives, and being part of our PMP Pals family. What is so special about this community is really just the continued relationships we have with our surgical oncologists, our medical oncologist, and then the need for the psychosocial. So it's all a continuum, but our heartfelt thanks. And we could be here forever. There's lunch. Our panelists will be here, during lunch, welcome for lunch, and so feel free to mingle. This is our version of the Meet the Professors for those of you going to ACT, our opportunity to continue to connect. But thank you so much. So another round of applause. And then maybe I'll ask Roberta or Lindsay to talk at lunch and when we're coming back.